you're with us?
Yes, I'm there. Shudeshna, how are you?
Yes, I'm good. How are you, Dolly?
Good.
Okay, so today we are here to have our 2 days. This is the concluding part of our 2 days program, and today our guest, our Doyle ma'am, will actually give a lecture session on the mental status examination. As we all know, before starting the session, I would like to share one thing with you all. That is, our respected HOD ma'am is now COVID positive, and all her family member as well is positive, and that is why she's not able to join
Mm.
us. She's not well. Um, so, Goldie, then can you please start your
Yes,
session?
yes. Okay. Shudeshna, just let me know if it is showing.
Not yet.
Not yet. By this. Okay. Good morning, students, and everyone present here. We will start with behavioral observation. Behavioral observation is the initial part of mental status examination. Okay. So, why I have separated these two parts, behavioral observation and mental status examination? Because many a times what happens that if there is a child who is intellectually disabled or a person who is uncooperative, we cannot do the mental status examination completely, the full mental status examination, but we can do this behavioral observation part, we can carry out that because it is dependent on our observation and case history taking. Okay, so first comes the consciousness part. When we assess under the behavioral observation, there are four parts. Okay, consciousness, general appearance and behavior, speech and volition. Hmm. So we are starting with consciousness. What is consciousness? Consciousness is the basic ability to relate to self and to the environment. And any disturbance in this elementary function would obviously affect the higher brain function that we will assess later, like attention, memory, intelligence. Okay. So, first, we need to assess if my patient is conscious enough to carry forward the mental status examination. So, there are four levels starting from alertness to coma. So, alertness, we will see that the person is awake and aware of all the normal external and internal stimulus. We can assess the person for mental status examination then. But if the person is lethargic, that is he or she is not fully alert and may drift off to sleep, then it is difficult to carry forward the mental status examination. And if the latter, parts, obtundation or stuporous state or coma state, it's obvious that we cannot, do the mental status examination. What is a stuporous state? There can be many type of stupors. There can be catatonic stupor, there can be manic stupor, there can be depressive stupor, there can be dissociative stupor. Okay, so there are many stuporous state that can take place in a person. So we have to assess if the person is conscious and alert. Then we will move towards the general appearance and behavior. In appearance, we have to see if the person is welcomed and tidy or not, if he or she looks very sickly, or sometimes for manic patients, they are overly made up. So we have to take a note of those. And then we have to go for the body build. Body builds are three types we know: ectomorphic, endomorphic, and mesomorphic body build. We have to write it down. For hair, is it well groomed? Is it disheveled, negligent? What it is? We have to observe that. Then, if the contact with surrounding present, fully present, partially present, or absent, that we need to know. And then eye contact. Eye contact can be present, absent, or partially present. Hmm. I can contact for you. You all know that for autistic children, the eye contact may be absent or partial. If a person is guarded, then the eye contact can be partial. What is the rapport with us that we need to report here. Rapport could be easily established. Rapport was not possible to establish. It was established but with a great difficulty. You have to, like, one of you were asking, if the patient gets irritated, then you have to calm that person down, and then you establish rapport. You talk different things with the person, the cause of his irritation and discomfort. Then धीरे धीरे the rapport, you can establish the rapport. So rapport established with difficulty. These things we have to know. And finally, attitude towards the examiner. The attitude can be cooperative, can be defensive, can be guarded, evasive. Evasive is the person is avoiding whatever you are asking, the person is avoiding. Is it fine? Okay. If the person is suspicious of your intention, that you need to, analyze or assess. If the person is hostile, many a times it happens, if the person is very agitated, then they can be hostile towards you, and you have to make the arrangement for that, so that you can protect yourself, you can escape from the situation. Your sitting arrangement should be such. Hmm. So these are the different kind of attitude towards the examiner that you need to analyze. Then coming to motor behavior, what was the motor behavior? Was it within normal limits, or there was hyperactivity, there was restlessness? There is a difference between hyperactivity and restlessness. Hyperactivity is overactivity, which is goal directed, and restlessness is overactivity, which is non goal directed. Was the motor behavior awkward? Was the person using many gestures? Was there any self-injurious behavior like head banging, like cut marks on the hands? Was there any psychomotor retardation? Was there tics? Tics, involuntary movements. You can refer to the slide also. Tics are rapid, irregular movements involving group of facial or limb muscles generally. There can be verbal tics, vocal tics, motor tics, uh, eye movement tic hoy. So there can be different type of tics. And if there is any mannerism, is there any stereotypy? Again, mannerism are behaviors that are goal directed, but it is not needed. The mannerism is not needed. Abnormal and occasionally bizarre performance of a voluntary goal directed activity. And it's kind of a dramatic in nature. It's written walking, but it can be a verbal mannerism also, a way of speaking, a dramatic way of speaking. And stereotypy is same, but it is non goal directed. It doesn't have any purpose. বাংলা একটা কথা আছে মুদ্রা দোষ। তো সেরকম একটা behavior. A person repeats that activity or that phase after performing the goal directed behavior, or simultaneously with the goal directed behavior. Is there any hallucinatory behavior? The person is talking to somebody, replying to somebody. Is there any touching behavior? Is there any utilization behavior? Whatever is there in the desk, the person is utilizing that, cannot inhibit his response. Okay, so these are some motor behaviors. There is also waxy flexibility. You may know that if you mold a person's hand or leg or whatever, he will like a wax. His movements will be very flexible and he will maintain that position. Whatever uncomfortable position you can, produce, he will maintain that. Negativism is just the opposite, that the person will resist any kind of movement. Ambitendency is like the person is moving forward and then backward, forward and backward. So both, cooperation and negativism, it is in his mind that what to do and what not to do. There is an ambivalence. So it is, when it is reflecting on the motor behavior, it is called ambitendency. Hmm. And then rigidity and automatic obedience. Automatic obedience is also whatever the examiner is doing with the hands and legs or whatever body parts of the client is automatically following that and maintaining that position. Then coming to speech, how do we assess speech? We see, is it soft? Is it loud? Is it audible, normal? What is the reaction to stimulus? You're asking a question to the person and the person is, sitting just like that. And she or he is replying on ek pore. It's a very delayed response to the stimulus. What is the speed of it? What is the pressure of speech? Is it a very slow speech? Is it a very rapid speech? Is there any pressure that you cannot, intervene in between? You cannot stop that person. He is just speaking and speaking. Prosody. Prosody or tempo means there can be normal, prosody. We take a pause. We follow a rhythm. But there are some person you will see that they speak in a very monotonous tone. For Asperger's disorder, the prosody is very flat, very monotonous generally. Hmm. What is the ease of speech? Is it spontaneous? Is it hesitant? Is there any slurring, slipping the speech, or stuttering, that there is a problem in initiating the speech, that is called stuttering? Is the speech is like whispering? She is speaking, but it's like, hello, I'm speaking. It's like that. Is there any muttering, muttering to self, or uh, he is speaking, but only when questioned. It is not spontaneous. And what is the productivity of it? Is it normal, or is it very মানে speaking বহু কথা বলছে, প্রচুর কথা বলছে, prolixity আছে? Is there any poverty of speech? The person is not speaking at all, or poverty of content? The person is speaking, but the content remains same, only talking about religious things, and only about it. A person is only talking about cars and not anything else. So there is the poverty of content. Is it relevant, irrelevant to the context or situation? You are asking something, the person is answering something, else. It is irrelevant to your question. Is there any coherence or incoherence? What is the, the arrangement of the sentence? Is it coherent? The words are coherent, going with each another. Is it goal directed, non goal directed, circumstantial, tangential? What is circumstantial and tangential? Circumstantial is you're asking a person, where is your office? He's answering that I go to office, 10 a.m. and then I do that and I take a bus and then do it. The bus generally is very crowded. My office is in Dharamtala. So he is basically answering your question, but in a circumstantial manner. And what happens in tangentiality? The person will just, her answer will be tangent. It will not be goal directed. He will just, beating around the bush, but not coming to the point. He will never come to the, goal that my office is in Dharamtala. He will see every other thing possible. I am just stopping here and uh, asking you if there is any query and anything regarding this part, because you will be, introduced to many new terms today.
So then
Ma'am, I
people
have
have.
a question.
Yes, yes,
Ma'am, can you please explain this catatonia? I did not quite get this.
yes. Catatonia is a kind of motor disorder, okay, motor problem. Hmm. If you're referring to the slide, then you can see that catatonia is a syndrome characterized by cataleptic posturing, but there are many symptoms. Catatonia is the umbrella term for that. There can be catalepsy, there can be stereotypy, there can be mutism, there can be stupor, negativism, automatic obedience, whatever. So, catatonia is the umbrella term for that. It generally denotes the motor disturbance. Okay, it's
Okay, ma'am.
about the muscle tone. Hmm.
Okay, ma'am. Thank you.
Anyone else? There are many new words. Do you want to know any of it? Then I will proceed. Okay, so we're proceeding towards volition. Now, what is volition? Volition is will. Volition is basically will. Willful activity. So, volition or will is a cognitive process by which individual decides on and commits to a particular course of action. It's a willful action. Hmm. What happens in some psychological disorders? You can see it is written made phenomena. Under made phenomena, there are three symptoms: made affect, made impulse, and made act. What is made affect? That whatever I'm feeling depressed or I'm feeling elated, it's not my effect. I'm made to feel like that. It's someone else's effect. It's not mine. So I'm disowning my affect. And I'm thinking that it's not mine, it's somebody else's. I am made to feel like that. Or regarding made impulse, I am made to do that. I am made to steal, or I am made to write. I am made to sing. Hmm. Whatever impulse I am having, sorry, I'm talking about made act. When I'm talking about singing or doing something, it is made act. I'm made to act this. If I'm feeling some impulse inside me, then it is not my impulse. I am feeling greedy. It's not mine. I'm made to feel greedy. I'm feeling like I'll harm somebody. I'll hurt. I'll like hit someone. I'm having that impulse, but it is not my impulse. I am made to feel that. Okay, made to experience that impulse. This is made phenomena. Generally, it is a characteristic of schizophrenic disorders. Then comes somatic passivity. What is somatic passivity? In somatic passivity, the patient will report that my body or soma is a passive recipient of all the sensations. I am not actively feeling anything. My body is a passive recipient of the feelings. Hmm. I'm just feeling these things. I'm not doing anything. Hmm. Next is echolalia and ecopraxia. What is echolalia? Echolalia is speaking after the last phase. For example, I am talking to you. The person will say talking to you, to you, repeating the last phase of it. And exactly like that, ecopraxia is carrying out the residual act at the last part of your activity. The patient will carry out that last part of the activity that is going in front of him. That is ecopraxia. And echolalia is about speech, and ecopraxia is about activity, repeating the last phase of it. Hmm. and if there is any other catatonic feature. Why it is, we were talking about automatic obedience and negativism. These are also, related to volition, because the person is not willfully doing it, he is made to do it. Uh, Automatic obedience, this waxy flexibility, they come under the cooperation phase. The person is extremely cooperative towards you, and he is doing everything you're asking to do him. And negativism is just the opposite. The person is resisting whatever is told to him. Okay. After volition, till this consciousness, general appearance and behavior, speech and volition, we can see by, observation. But after that, we need to ask the person, examine by asking. First, we are asking the cognitive, assessing the cognitive functions. What comes under cognitive functions? These few. You may ask me some questions. I'll have my water in between. Any question?
Ma'am, can you please repeat the somatic passivity?
Yes, somatic passivity is the patient will report to you that I am passive, I am not doing anything, but I'm feeling many things. My body is a passive recipient. My body is passively receiving whatever is going on. Like, I'm feeling pain, I'm not doing anything, my body is just feeling like that, and the distress is also like that. Yes, I'm feeling it, my body is receiving it, I don't know why it is there, my body is just receiving it. Okay.
Okay, ma'am.
My body is a passive recipient of all the sensations. I am not doing anything to receive anything. Hmm.
Okay, ma'am.
This is also characteristic of schizophrenia. Coming to cognitive functions, first comes orientation. So we can see there are many: orientation, attention, concentration, memory, abstraction, general intelligence, judgment, and lobe functions. In orientation, we see if the person is oriented to time, place, and person. We ask what is the time, day, which year, which month. That is also we ask. To the place, where have you come, what is this place, how did you come here. And then who I am, you can see many people around you, who are they. If the person orient to time, place and person, that we need to assess first. Then coming to attention and concentration. What is attention? You all know that it is the ability to attend to a specific stimulus. In mental status examination, we assess it like that. If the person is able to attend to a specific stimulus without being distracted by extraneous, internal, or environmental stimuli. By that, what do we mean by that? By extraneous, you're asking something and the person is responding to his hallucination. That is the internal stimuli. So the person is not being able to attend to whatever you are asking or saying. So that you need to assess. If the person is attentive enough, we generally give the impression that attention and concentration is, it is, easily aroused and sustained. Easily aroused, easy to arouse but not sustained. Difficult to arouse and not sustained, and difficult to arouse but sustained. These are the, four categories that we generally give in the impression. And how do we assess it? We can assess it by digit forward and backward. And the concentration part, which is the sustained attention part, we assess it by serial subtraction. Hmm. Generally, we ask 100 minus 7, just calculate like 100 minus 7, 93 minus 7. Okay, so we assess if the person is able to sustain the attention and calculate it, back calculate it. And for younger children, you can give 40 minus 3. Hmm. Either 100 minus 7 or 40 minus 3, depending on the person you're assessing. After attention, we assess memory. What is memory? What do we see in memory? That if the person is able to store the information for later recall. You all know that there are different stages of memory, that is encoding, storage, and retrieval. Hmm. So we will see that if the person is able to store whatever is, whatever information he or she is having, and being able to retrieve that whenever needed. Appropriate retrieval of the information. And based on the time we assess it. We assess it through remote memory testing, recent memory testing, and immediate memory testing. Now, what is immediate memory? Immediate memory is something like short term memory, because it is we have classified it depending on time. So up to 30 seconds maybe, if the person is able to recall something, that comes under his immediate memory. We can assess it by digit forward and digit backward. Do you all know what is digit forward and digit backward? I think you have some idea. I know, because in graduation also you have done it maybe. Hmm? If anybody doesn't know, please ask me. I'll show you. Okay. What is recent memory? Recent memory. Bolo?
Can you once explain that?
Yes, yes. Digit forward is, suppose I ask you, what is your name, dear?
I'm Gargi.
Gargi.
Gargi Rajan.
Okay. Okay, Gargi. Uh, I'll um, I'll tell you some numbers. You just have to digits. You just have to repeat after me when I uh, যখন আমরা সামনে করি we give a indication, but এখানে তো সেটা হবে না. So you can just repeat after me. I'm telling 3, 9.
3.
Uh, After I finish, okay. 3, 9, 8, 2. Gargi, tell me.
3982.
This is digit forward. We can go up to 9 digits. Generally, you know that there is this Miller's magic number, that is 5 plus minus 2. Generally, the attention span is like that. Till 7 digits, a person can remember. And digit backward is just the opposite. Gargi, whatever I'll say, you have to say it reverse. The sequence, you just need to reverse the sequence. Okay. I'm telling you 5, 2, 6, 4. Please repeat.
4, 6, 2, 5.
This is digit backward. Okay. Then word recall. Word recall is for new learning, just to assess the new learning. New learning is I'll say 5 words, and there will be a time gap in between, and you have to recall the words that I have told you. So we will that way see if the person is able to learn the words which are not associated with each other. Different category word bola. One from one is some abstract word, one is from nature, one is from daily use. Like that, 5 words we can choose. In recent memory, what we ask, if any of you have done PGI memory skill, you will know what comes under recent memory, what comes under remote memory. In recent memory, we generally ask questions related to last 48 hours. What have you eaten in your breakfast? What did you eat last night? Who came to your house to visit you? This kind of questions that we ask under recent memory. And for remote memory, we can ask personal questions, personal memory, not personal questions, like personal memory questions, and some impersonal memory questions, for example, current affairs and all. In personal remote memory, we can ask what is your age, what was the name of your school, how many siblings you are, what is the age of the, or someone has to mute their system.
Yourself mute.
And
Students, please yourself mute.
in impersonal memory, what do we ask? We can ask about when was the Babri Masjid event happened. When was the earthquake happened in Gujarat? Maybe. So the affairs that we read in newspapers and all, this kind of questions. Okay. Coming to abstraction, what do we ask in abstraction? What is abstraction? Abstraction is generally the formation of general ideas and concepts by extracting similarities from particular instances. For example, I ask you, what is can you tell me the similarity between mango and banana? Can you tell me the similarity between lake and mountain? Can you tell me the similarity between, cat and dog? So these are some questions that we ask in similarities. And in proverbs, what do we ask? That grapes are. What do you mean by, you often come across these proverbs that grapes are sour, नाच ना जाने आंगन टेरा. So क्या meaning क्या होता है इसका? What does it mean? So how well the person is able to tell you, elaborate on that, that is their abstraction ability. So generally, if there is any organic problem or if there is any intellectual disability, the person cannot tell you the exact answer. They will just tell that yeah, grapes तो sour थे, मतलब खट्टे थे, इसीलिए बोला गया होगा. The the एकदम जो concrete, what is the concrete meaning of it, that the person will repeat, that the patient will repeat. Achha, now for example, if someone says what is the similarity between aeroplane and bird, इसका similarity क्या होता है? तो they will say that both can fly. So the answer will be a functional one. Okay, if a person is asked that what is the similarity between cat and mouse, they will reply maybe they have four legs. That would be concrete abstraction, concrete level of abstraction, because they are going by the physical features. If they go by the functionality, anything like they jump, they bite, anything, any function, then it will be functional level of abstraction. If they say that both of them are animals, then it is conceptual. If a person says that sab to bhagwan ka, matlab they are all creation of god, this is over abstraction or philosophical abstraction. Okay, am I clear? বোঝানো গেল এটা? আমি তাহলে পরেরটা
Yes,
মুভ
ma'am.
করছি. Okay, how many time left? How much time left? 10. Okay. We are coming to mood and affect. What is the difference between mood and affect? Affect is cross sectional. Affect is cross sectional. Like it's like today's weather. It is sunny. It is bright. Okay, this is affect. Today I'm fine. I'm happy and gay. This is affect. This is cross sectional. And what is mood? It is over a period of time. It is maybe the climate of that particular area or the geographical area. Hmm. My mood generally is happy, normal, normal, cheerful. So that is my mood. And if my predominant mood is like, no, I'm generally gloomy, I generally feel low, that is the mood. Today I am okay, but I generally, my mood generally, it stays okay, it's a bit sad. That is mood. And this is affect. Affect is cross sectional, mood is longitudinal. What is subjective effect? Subjective effect is the answer your patient is giving you. How do you feel? Your patient is saying that I am feeling little anxious. That is the subjective effect. What is objective effect? What you see. What you see in your client objectively. Hmm. You see that the person, yes, he seems little sad. That is the objective effect. What is the depth? Is it shallow? Is it deep? That you need to assess. He's saying he's depressed, but the depth is not there. He's like, yes, I'm depressed. The depth is not there. What is the range? Is it normal? Is it restricted? Is only, the range is on the negative side, or no, it is a normal range. Sometimes, some days it is happy, some days it is sad. The whole range is there. What is the stability of affect? Stability is stability is if the affect is stable or labile. Stable means it is consistent over a period of time, or it is labile, meaning rapidly fluctuating. In mania, it happens. In cyclothymia, it happens that there is labile effect. The person is crying and then laughing and then again crying, then again normal. That is the lability of affect. Is the affect appropriate to the situation and thought? A person is reporting something, disturbing to you, distressing, but he or she is laughing. So that is not appropriate to the thought or situation. Or the situation is a very formal one. The person is laughing. That is also inappropriate to the situation. Is the affect communicable to you, or you're not? It is not getting communicated. The person is reporting that I'm depressed or I'm happy, but it is not coming to you. It is not reaching to you. Hmm. And what is the reactivity to stimulus? If the person is uh, uh, for example, you're carrying out this mental status examination, and then there is something funny happened in the situation. The person is non-reactive to that, just making a straight face and sitting there. So not reactive to the stimulus. It can be a funny stimulus, it can be a sad stimulus or whatever, but the person is not reacting to that. Then coming to thought, it's huge. Assessing thought is huge. So generally in thought, I'll take a minute. In thought, there are four components, four characteristic of thought. Just imagine a river. Hmm. A river, it has a form or a shape. A thought is like a river. It has a form. You see, in a river, there is the amount of water. That is the stream. Hmm. Whatever the person is carrying is the content of the river, and here, whatever our thought process is carrying is the content of our thought. And the river belongs to maybe Bangladesh, maybe West Bengal, maybe Orissa. That is the possession of the thought or the river. Okay, so there are four characteristics. Now we will assess যে কোথায় কোন সমস্যাটা আছে. Hmm. Let us start with the thought stream. So what it is? The amount of water in the river. Remember? Hmm. So is it normal? Is it overflowing? Is it less? The water is less. সেভাবে we will assess the thought stream. Is it normal? Is it retarded? Is it accelerated? So if it is more, then it is accelerated. There comes this flight of ideas, prolixity, pressure of speech. These, symptoms. If the thought stream is accelerated or more, if it is less or very less, that is retarded, there can be thought blocking. There can be circumstantiality. Circumstantiality also comes under, a form of thought. And perseveration. I am defining. Thought blocking is a person is talking to you and suddenly stops because he just would feel blank. No thought coming at all. A characteristic of schizophrenia. Circumstantiality, we have discussed in speech, the same thing. Perseveration is you are having some idea which is persisting beyond the point of relevance. You are doing a task or you're thinking about something. Here we are talking about thought. So you're thinking something and thinking about it beyond the point of relevance. It is not relevant anymore, but you're still thinking about it. You cannot help it. You cannot help stopping it. Okay. So it is perseverating. Generally in OCD, the perseverative ideas are there, that the threat is gone, the need is gone, the demand is gone, but still I am thinking about what would happen if I don't do it, what if happen if I don't count it. So I am in my mind, I'm perseverating with the thought. And what is flight of ideas? Flight of ideas are
Ma'am,
many
I
ideas.
have a
हाँ,
question.
बोलो.
Ma'am, in perseveration,
Hmm.
if the person is repeating same words, like it's
Hmm.
not echolalia, but the person is
Hmm.
talking beyond the
Yes,
points and
yes,
concentrating on the
yes.
same words,
Right.
repeating same sentences,
Yes.
is it perseveration or
It
echolalia?
No. In echolalia, the person will repeat just the last phase. Hmm. Just the last phase. Like I am talking to you, this much. Okay. This will be echolalia and this will go. And there will be a new sentence, there will be a new echolalia. Okay. But in perseveration, what will happen? In organic cases, not in OCD. In OCD, it is different. In organic cases, what would happen? I am asking you, what is your name?
Ma'am, Shushmita.
Shushmita. What is your father's name?
Raghunath
Shushmita.
Bhattacharya.
No.
Okay. Oh,
He
sorry.
will
Okay.
perseverate. The same answer beyond the point of relevance. The question may change, but the answer will be same. Okay, this is for organic cases, but in OCD it is very different. In OCD, it will be that you have this idea of contamination, that my desk is dirty, so wiped it, you cleared it, this is now clean, but then the person would again have the idea that my desk is not clean. Okay, so the idea remains even after clearing it.
Oh,
That is the kind of perseveration happen in OCD. And in organic cases, it is very mechanical perseveration. It is different. Okay.
okay. Okay, ma'am. Okay.
Acha,
Thank you.
in flight of ideas, what happens? There will be many ideas. In many cases, generally it happens in mania phase. There are many ideas, and there are this train of thoughts. the person is speaking about space, and then speaking about universe, and then about this planet systems, and then about water conservation, and then about ecosystem. And you will think that the person, what is he saying? But in his mind, everything is related. It is not incoherent. It is not loosening of association. In his mind, he knows the sequence, or the they are related. But the force, the way he will speak, we will feel that these are not related. This will be flight of ideas. There may be multiple ideas related. Hmm. What is prolixity? It is less than flight of ideas. It is more of beshi kotha bola, talking much. Hmm. Uh, irrelevant কথা বলছে, relevant কথা বলছে, একটু বেশি বলছে। বাংলা একটা কথা আছে, বাচালতা। It is prolixity. And pressure of speech. Pressure of speech, we have discussed in speech domain also, that it is overabundance of speech, and in a manner that you cannot stop a person. He will speak and speak, you cannot intervene in between. Okay. Then coming to form of thought, that is the shape, or form of the thought. So there may be poverty of content, we have discussed. There may be derailment. Derailment is losing the track, dhire dhire, gradually drifting from the normal track. There may be loosening of associations. All our sentences are associated with each other, but there may be some loosening. In case of schizophrenia, there may be some these are this form of thought. If there is any disturbance or disorder in it, we call it formal thought disorder. So these all comes under formal thought disorder. So there may be loosening, loose associations. The associations are not intact. There may be neologism. Neologism is using new words. Using new words like this is a laptop, but the person may call it taplop, maybe. So it's the word for him, taplop. This is neologism, and another neologism is using a old word in a new way. Like the person will call the bottle as laptop, he will mean it. Okay, that is a new word, new dictionary, new vocabulary for him. Word approximation is like you are again beating around the bush, not around the bush, around the word. Okay, you're not telling the exact word, but something related to it. Not, say again laptop, maybe something related to it is there. We work with it, we keep it in the on the desk. We work, there are keyboards. These things they will say. What is word salad? Word salad is gibberish. Like you have made a plate of words, and which doesn't mean anything to you, but obviously it means something for the person who is speaking it. Incoherence is, there is no coherence in the syntax of the sentence. Incoherent word would be kind of example of a jumbled sentence, jumbled word wala sentence. What is clang? Clang association is rhythmic. It's very funny to hear when a manic person comes and tells you. It's very humorous actually. They will try to have rhythm, অন্তমিল যেটাকে বাংলায় বলে, সেই জিনিসটা with every sentence he says. Like I'm saying, every sentence he says, it stays. It doesn't mean anything, but the says and stays means. So this rhythm he will follow. He will follow just to maybe swallow. It's like that. It's very funny. So it's clang. Uh, Illogicality you can understand. Tangentiality we have discussed. Distractible speech you can understand. Perseveration, circumstantiality, loss of goal, and self-reference. Self-reference is whatever he will say, there will be a self reference that I had this idea or I had this, it happened to me. Whatever you are asking, maybe you are asking him about, again, about his children or his work. Where do you work? I work here. I actually did this to, to flourish this job, or I actually made this. There may be some grandiose ideas related to it. And when you do Rorschach na, there also you note these personalized responses. It is like that. He is pointing towards maybe aquaguard out there, but he will talk about, uh, I have a water purifier system back at home, and it functions like that. So again, his home, his reference, like that. Then comes thought possession. In thought possession, there are obsession and compulsion. Hmm. Why it is under possession? That the obsession is against our will. And do you all know maybe what is obsession and compulsion? Obsessions are repetitive, irrelevant thoughts which comes to our mind against our will, and it is difficult to control. And compulsion is the act which we feel compelled to do to neutralize that obsession. Hmm. So under thought possession, there comes obsession and compulsion, and then thought alienation. Under thought alienation, that my thought is not my thought, only my thought. It doesn't remain my private thought anymore, but my thought is being inserted into my head. That is thought insertion. There may be thought broadcasting, that everybody around me is getting to know my thought. My thought is being broadcasted in Akashvani, in radio, in TV. It is getting broadcasted everywhere. How do they know that I was thinking this? Then thought withdrawal, that I'm not having thought because somebody is taking it out from my mind. So I'm not having any thought because of that. Every thought, whatever is I'm thinking, it's getting withdrawal. Okay, these are thought insertions and broadcasting and withdrawal. These are again symptoms of schizophrenia. And thought content, okay, I missed it here. In thought content, there may be preoccupation, and delusions. Okay, under preoccupation, you will see that there may be somatic preoccupation, there may be sexual preoccupations, there may be religious preoccupation, there may be preoccupation with the precipitating factor. Maybe it started with a breakup, and I am, preoccupied with that thought. Maybe it started with death of a family member, and I'm preoccupied. I'm thinking and thinking about it. I cannot, detach myself from that. So that is the preoccupation. And there may be ideas of reference, ideas of persecutions, ideas of grandiosity, ideas of guilt, and there will be delusions. What is the difference between ideas and delusions? They are both under thought content, but the ideas can be challenged. I think all my neighbors are against me. Do you really think so? Yes, I think so. But is it possible that they're not against you? And maybe you're just thinking it like that? Yes, that is also possible, because sometimes they're nice to me. So this is ideas level এ আছে এখনো. And if it is solidified, and it is a false, firm, unshakable belief, then it is delusion. Okay, that is the difference between ideas and delusions. And then there can be overvalued ideas. What are overvalued ideas? That my again neighbors or relatives are doing black magic on my son. They are doing this all whatever tuk tak on my son. This is something culturally accepted. Hmm. You will see 70% people would believe in that. So we cannot call it delusion or ideas or something like that. We just call it overvalued ideas. Hmm. So what are the content we just discussed? Preoccupations, ideas, delusions. Delusions are false, firm, unshakable belief. When the ideas are very solidified and we cannot challenge it, it becomes delusions. Delusions can be primary delusions and secondary delusions. What are primary delusions? That the delusion is a systematized one and it formed on its own. Hmm. And I just started thinking of my neighbors are against me, my relatives are against me, or I'm thinking that I'm a superpower. I'm a person who has a supreme power. I can save the world. I can change these things. These are grandiose delusions. These may be primary delusions also. If it is a primary delusion, we categorize it when we diagnose it is under delusional disorder. But sometimes what happens, delusions are secondary to our mood. Hmm. Like I am depressed. I'm very depressed. That is why I am thinking the world is coming to an end, which is a nihilistic delusion. I am in the manic phase. That is why the delusion is grandiosity, of grandiosity. Hmm. So these are secondary to our mood. And then this is all about the thought contents. You can ask me, you can stop me and ask me questions. And we will now discuss perception. To conduct MSc, what you need to do is you need to have a very good understanding of general psychology. General psychology and cognitive psychology. In clinical psychology, you just cannot study clinical only. You have to have understanding of general psychology, cognitive psychology, physiological psychology, which is a biological foundation of behavior. Hmm. Otherwise, you will not be able to diagnose a case properly. Coming to perception, in perception, we will see if there is any abnormality or not, if the perception is normal or abnormal. What may be a kind of a abnormal perception? Perceptual problem is hallucination. Okay, what is hallucination? Hallucination is a perception without stimulus. There is no stimulus, but I'm perceiving something. What happens in illusion? In illusion, the perception is distorted, but there is a stimulus present. I am seeing a snake where there is a rope, but the rope is there, the stimulus is there. But in hallucination, we will see the snake where there is no rope, there is no stimulus. Okay, so that is the difference between illusion and hallucination. Now, coming to hallucination, there are many kinds of hallucination. I'll not elaborate on that because in MPhil you will learn all those things. You have to finish it also. In perception, we will see what is the projection. Is it external or internal? Is it coming from outside? I'm listening that I am having these voices which is saying that I am good for nothing. I'm worthless. I'm a fool person. Whatever is saying, is it coming from outside or from inside, like inside my head? If it is from inside, it may be a pseudo hallucination. Hmm. And if it is outside, it is hallucination. And then modality, which modality you are perceiving it? Auditory, visual. Hmm. There may be some olfactory hallucination. A person is always, smelling something. Uh, there is a smell. There is a smell. Something rotten is there. This kind of olfactory hallucination may be there. There may be somatic hallucination, that is called formication, that a ant or something is crawling up all my body. Hmm. What is the content of hallucination, that we need to understand, that what is it saying, what is it doing, what is it telling? Is it telling that you are going to die? Is it telling jump out of the window? What is it saying? Hmm. And what is the response to the content? What your patient is responding, how your patient is responding to the content. He's closing his eyes, ears, running away from that place, replying back. What is he doing? What is the frequency and diurnal pattern? It is more in the daytime or in the night time that you need to write. And there is thought echo, that whatever is I'm thinking, I'm hearing the echo of it. There may be second person hallucination, that someone outside, like some second person is talking to me in a you manner. You are this, you are that, you are a coward, you don't deserve anything. Or there is third person, that people are talking about me. There is no you statement. There is voices arguing among them. They're arguing about my being, my well-being, or my illness. Okay, that is third person hallucination. And there may be, I was telling now, ki there may be different types of hallucination, like extracompine hallucination. Extracompine hallucination is the hallucination you cannot, it is beyond your sensory field. Your patient is telling you that yes, in London they are talking about it, and I'm being able to listen to it from here without any telephone, of course, just through auditory system. That is extra combined hallucination. There may be there may be autoscopic hallucination, that is about your body, and you're viewing your body double. Reflex hallucination, that hallucination stimulation in one modality, like sneezing causing headache. Sensation in one modality is causing hallucination is other sense modality. Sneezing is causing headache, that is reflex hallucination. There may be functional hallucination, there may be pseudo hallucinations also. Functional hallucinations are like it's a same modality thing. Reflex hallucination is a cross modality thing, and functional hallucination is the same modality thing. You're listening to birds chirping, and the sound of water falling at the same time. Hmm. Both at the same time. That is functional hallucination. Okay, we will finish quickly. There are other phenomena also that you need to inquire, examine in your patient. That if there is any depersonalization experience, that out of body experience, or I'm not feeling that I'm the same person anymore. Derealization experience, that my surrounding seems unreal. In depersonalization, the person seems unreal, and in derealization, the surrounding seems unreal. Retrospective falsification, what happens in depression or in paranoia, that maybe something has started 2 days back, or 2 months back. You will feel, the person will feel that it has started ever since, matlab, from the childhood. My parents have been like that from my childhood, but maybe for last 2 weeks they are doing it. So it is retrospective falsification. And confabulation is making up something. In dementia, it's a characteristic of dementia. It's in the memory dysfunction domain, that you don't know something, You don't have knowledge about something, but you are confabulating it. Your memory is confabulating it and telling that no, this happened, this actually happened. Okay, so your memory is confabulating and telling you something which you're just trying to attempt that. And finally, you need to assess the insight of the patient. Is it in the denial state or in the intellectual or emotional insight state? That you need to assess. I'm going fast because we don't have time. Finally, what do? You reach to the diagnostic formulation with all these informations. You're now full of informations. You now have to organize this information in your diagnostic formulation. In diagnostic formulation, you write only the positive findings that you have from this case history and MSc, and you formulate your diagnosis, and you reach to a provisional diagnosis and a differential diagnosis. And you also find out from the history what are the prognostic factors. Prognostic factors, what is prognosis means? Prognosis means the prediction of the recovery. What are the chances of recovery? What are the good factors that is there in the patient that will help him to come out of it? And finally, you uh, you know you give a management plan, assessment plan, and therapy plan both. Okay, so now we end it here, and I'll request you to, if you have any query, you can ask me.
Ma'am, this is Sarkojit.
Yes, tell me.
May I?
Arpajit, did
Basically,
you
I just
ask me about caste yesterday?
yes, ma'am. Yes, ma'am.
Okay, I just forgot to tell you a story that one of my client, he had this inferiority regarding Brahmanism. He wanted to be a Brahmin. He thought that he has been discriminated because he is not a Brahmin. He is half Brahmin. He is Brahmin from his mother's side, but he would feel that if he would have been a Brahmin, then he would have been a very good looking and a popular person. Hmm. Okay. So what is today's
I see.
question?
I see. So, ma'am, the question I would like to ask
Hmm.
today is that the methodology that we discussed in the last 2 days, basically, is this applied for every client, or are there other methodologies as well?
No, this is for every client. This is a standardized one. Okay. For every psychiatric patient, we go by this method. For children, there are few more techniques like animal test, a three-wish test. These are there, but this is for every client.
So, basically, how many sessions are usually required for completing this test?
How many sessions? We do it in a one session. Case history and MSc should be taken in the first session. It may take 2 hours or more than that, depending on your patient speed and everything, and your understanding, rapport establishment, everything. But it is ideally should be finished in the first day of your interview, and you can repeat the MSc. You can repeat the mental status examination part every day in every session actually. And for indoor clients, indoor patients that we have, we need to repeat MSc every day. To just take a note of their progress.
Okay, so based on this, the therapies are provided as per necessity.
Yes, first assessment, if any assessment needed, and then therapy planning.
All right, ma'am. Thank you.
Hmm. Generally, if you take the case history in a very empathic manner, it is very relieving and supportive for the client. So it is just not uh, case history taking. It is also a kind of validation. The person is able to share things with you. It is a relieving experience for them if you do it in a right manner.
I see.
You can refer to Kaplan and Zadok synopsis of psychiatry. You can refer to Fish psychopathology, of course. You have to if you want to prepare for MPhil and if you want to know the psychopathology also. And this Strabon Black. I'll share the soft copy with your faculty. Any more questions?
Yes, ma'am. I'm
Student,
Shantan Chakraborty.
Yes, tell me, Shantan.
Uh, Ma'am, the various parts of the history, depending
Mhm.
on the case, does the importance change or the importance of all parts of the history taking is same for every case?
It is same for, it should be same for every case. You know why? Because we don't know. The patient would not know what to report and what not to report. Hmm. So when you are giving importance to every aspect and asking this in detail, then you will know. Acha, okay, in family history it was there. Okay, in sexual history it was there. I just thought he's a 15-year-old child. I'll skip it. We generally don't do it with children. We just ask it the interest and romantic interest and all. We don't do the sexual history part. But if he's just 19 years, I'll ask about his sex life. I should not. But you will see that there is the problem. So just try to give importance to every part. Come on.
Yes, ma'am. Thank you.
Mm.
anyone else having any question? Um, you can ask our ma'am. Okay, so we are at the end of our 2 days lecture program. So, Weldy, thank you so much. Thank you so much. We know that you're not well, and still you took time and gave us your precious time. You explained
Thank you.
things beautifully. So, thank you. Thank you for that. Thank you so much. And I would like to thank all other faculty members as well for cooperating and for arranging this program. I would also like to thank our Dean Sir, our management for giving permission for organizing this 2 days lecture program. And also, I would like to thank our students, all the participants who actually gave time and actually made it successful, this 2 days lecture program. And also thank to the digital team who actually helped us to make a poster, beautiful poster, and also they actually made a Facebook live of this lecture program. So if anyone wants to want to listen or see this beautiful presentation afterwards also, they can actually see that, they can take help, they can actually see that, they can actually listen to that beautiful lecture again. And I would also like to thank our HOD ma'am as for arranging this program. So thank you so much, all of you. Once again, Doeldi, thank you so much.
Thank you thanks to you all, and thanks to the students also because they have been interactive and very patient. Thank you, Team Neotia.
Thank Okay, so hereby we are ending this 2 days lecture program. Thank you all.
Thank you, ma'am.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you, ma'am. hallucination, we will see the snake where there is no among them. They're arguing about my, being, my well-being, or my illness. Okay, that is third person hallucination. It's in the memory dysfunction domain, that you don't know something. You don't have knowledge about something, but you are confabulating it. Your memory is confabulating it and telling that no, this happened, this actually happened. Okay, so your memory is confabulating and telling you something which you're just trying to attempt that. And finally, you need to assess the insight of the patient. Is it in the denial state or in prognosis? Means the prediction of the recovery. What are the chances of recovery? What are the good factors that is there in the patient that will help him to come out of it? And finally, you, say, you give a management plan